You're on.
All right, so what I was asked to talk a little bit about was tetralogy flow and similar types of patients, and what are the indications for a repair during infancy versus a later repair. So this is going to be very simple because I'm not going to teach you, you guys are going to tell me the answers. I always make this interactive. So if you try to not answer, I will call on you. So first of all, why don't you guys tell me what is tetralogy flow?
The combination of four symptoms, VSD.
And that's symptoms for...
Or four anomalies.
Okay.
Yeah, sorry. So
VSD, there's one. What else?
Overriding
aorta, yeah.
Right ventricular hypertrophy.
Yes. What's the fourth?
Pulmonary atresia or stenosis.
Well, pulmonary stenosis, too, not atresia. So, correct. So, from a developmental perspective, all of that can be explained by one thing, which is what's called the infundibular septum is the septum that lives between the aortic and the pulmonary valves. And that septum can be deviated either anteriorly or posteriorly. And if it's anteriorly deviated into the RV outflow tract that causes the pulmonary stenosis. Because it is no longer lined up with the ventricular septum, there's a ventricular septal defect. So you have pulmonary stenosis and a ventricular septal defect. RV hypertrophy is because of the outflow tract obstruction. And then what's the fourth one?
what do we say? The overriding aorta?
Overriding aorta. Okay, so the point is that as that septum, which is attached to the aortic valve, moves anteriorly, it brings the aorta with it, overlying the other portion of the VSD, which is what causes the overriding aorta. So there's really only one defect that causes all four of these anomalies, which is infundibular or anterior malalignment of the infundibular septum. So what are the typical symptoms of tetralogy flow?
Well,
How do you make a diagnosis? How do you know someone's got it?
I mean,
Echo.
spelling,
Can be
decreased
TET
pulmonary
spells.
flow and times of
Okay, so what are
Or
TET
increased
spells?
pulmonary
You guys
pressure.
brought it up. What are TET spells?
And you have a little bit less of the flow going to where it needs to go, so sometimes it's
So where does it need to go? You're right. But what do you,
right-wise, like a lot of times they like would find it during like feeding or something like that.
okay. So it occurs during times, oftentimes when we think about it as babies are stressed, something like that, and we'll explain it a little bit more scientifically. But what it really is it's an abrupt decrease in pulmonary blood flow. So the way in which you diagnose it is a patient turns blue. Now, when you have outflow tract obstruction in tetralogy flow, you have a murmur because you have turbulent flow going across that infundibulum and potentially a narrowed pulmonary valve that causes some degree of turbulence that causes the murmur. That's where the murmur's from in tetralogy flow. It's got nothing to do with VSD. The VSD are typically non-restrictive VSDs. They're big holes. So the pressure in the left ventricle and the pressure in the right ventricle is the same because there's basically no wall between them. So it's not a VSD murmur you hear. It's that blood trying to get out to the pulmonary through the pulmonary valve. When someone has a TET spell, what happens? They can't get that blood out the pulmonary valve, so they turn bluer, and more blood goes right to left across the VSD. So actually, the way you diagnose a TET spell is not just the history and the circumstances around it and a sudden drop in SAT, it's that their murmur actually decreases because they have less turbulent flow going out to the lungs, more going across the VSD and out to the body. And you can't hear that flow. You just hear a decrease in the pulmonary outflow. Does that make sense? So times that it happens is when there's a change, a sudden abrupt change, usually in systemic vascular resistance. Because remember, where the blood's going to go, so if your blood's sitting in the right ventricle, you have two places to go. Out, across the pulmonary valve to the lungs, or across the VSD out to the aorta. The amount that goes out the VSD into the aorta is going to be determined by how much obstruction there is to the pulmonary bed. If there's a lot of obstruction, you're going to have blood going from the right ventricle across the VSD to the left ventricle out to the aorta. That's blue blood getting into pink circulation. You'll be desaturated. Okay? In a TET spell, what can happen suddenly is that a baby can have a low systemic vascular resistance. And normally your systemic vascular resistance is about 10 times higher than your pulmonary vascular resistance. But if you have some degree of outflow tract obstruction out to the lungs, that adds to the relative pulmonary vascular resistance. So they're closer together. But if you suddenly drop your systemic vascular resistance, that's going to make blood want to flow through the VSD out to the aorta more than it does at baseline. So when do kids have a sudden drop in their systemic vascular resistance? Well, most commonly, it's when you stick them into a bathtub and you vasodilate them. Okay? So very commonly, you'll hear that, you know, a kid in the bathtub in the morning and mom was giving him a bath, got him out of the bathtub, and the kid was totally vasodilated, and suddenly they have a TED spell. So that tells you part of the way in which TED spells can be treated too, which is to try to reverse that process. So drugs that we use to try to treat TED spells, one of the big ones is something that increases your systemic vascular resistance. So the most common that used to be used was phenylephrine. And we have a kid over in the first bed space over here who was having TED spells and was being brought in for a totally unrelated reason and started spelling and got admitted to the PCTU, extremely blue. SATs were in the 20s, and he was getting essentially no blood flow out to his lungs. And what probably changed abruptly was some relative ratio between the systemic vascular resistance and the pulmonary vascular resistance, such that the blue blood wouldn't go out to the body. So TED spells is one of the ways in which you diagnose tetralogy flow. The other way is that kids are continuously blue. There's some degree of desaturation. You now know that in every NICU in the state of Michigan, it's now a law, it's required, that every newborn is screened by pulse oximetry. And part of what you're looking for are kids who either have a difference between the upper and lower extremities when it comes to SATs, and what kind of problems would cause that. Coarctation, obstruction to the aorta, interrupted arch, you consider. That's one. The other would be kids who are desaturated on all four extremities. And the most common diagnosis for that is tetralogy flow and its variants. So tetralogy flow is the most common form of cyanotic congenital heart disease. However, what's the most common form of cyanotic congenital heart disease in the newborn? It's not tetralogy flow. What else makes kids blue when they're born? No, hypoplast is a common mixing lesion. They basically have one pumping chamber pumping in two circulations. They can be desaturated, but if you ever see the kids down in the NICU, I almost called it Poland, see kids down in Brandon, I guess it is, who have hypoplastic left heart syndrome, big, chubby, healthy-looking kids who often have SATs in the 90s, because they're just pouring blood into their lungs. May not be getting to their body, but it's a common mixing lesion. Common mixing lesions don't have to be very blue. But what's a very common cyanotic lesion that we see, you know, a dozen times a year here? What's that?
Be PFO.
So a foramen ovale, which way should a foramen ovale shunt? Right to left or left to right? I don't want to get too far off task, but it's pretty clear. It should go left to right.
Yeah, that's
Okay.
the other one.
So it doesn't go right to left typically if the rest of your heart is normal and your lungs are normal. So that's pink blood going to the blue side of circulation. That's not going to desaturate you. So the answer is transposition. So transposition of the great arteries is the most common form of cyanotic congenital heart disease presenting in the newborn. But the most common type of congenital heart disease that's cyanotic overall by far is tetralogy flow and its variants. So bottom line is you might not pick these kids up at birth if they're not very blue. So the things that might bring them to attention would be, number one, the murmur, because the murmur is usually loud. It's a pulmonary stenosis murmur. I mean, this is the kind of murmur medical students can hear, you know. Secondly, the thing that will bring them in is TED spells. Now, if you just sort of, as a general rule, kids will not spell in the first month of life. So if they're calling you about a newborn and they're saying, I know this kid's got tetralogy flow and he keeps desatting, he must be spelling. There's probably 1,000 reasons why our kids desat. But it's not likely to be spells. Spells are something that occur usually after the first or second month of life. But in fact, that kid over there is, he's like 2 months old. So the fact that he started spelling now makes a lot of sense, but he probably wasn't doing it before. We don't quite understand the reasons for that, but it's a very common observation. So when kids spell, the problem is they can't get blood out to their lungs. They get very, very blue, and then they can get so desaturated that can affect their heart function. So the next thing that happens is they get very tachycardic, try to compensate, their blood pressure falls, and it can be a fatal event. There's a certain number of kids with tetralogy flow who die every single year across the country due to TED spells that they can never get out of. But the way in which you try to treat a TED spell, so what do? Trying to get blood flow to the lungs,
So you
trying to
wanna
decrease it going to the body, right?
Cause obstruction to systemic blood flow, so you
Which-
crunch up their legs.
Right, so you bring their, so, knee to chest position, you bring their legs, what you're doing is kinking the big arteries in their groin, increasing afterload, just like we were talking about with the drug, acutely, and trying to force that blood to go out through the lungs and not go out to the body. So that's one thing you do. What else do you do?
Things that would lower pulmonary resistance.
Yes, and
Oxygen.
you're absolutely right, and that is the classical teaching. The truth is, most tetralogy of Fallot patients do not have a real increase in their pulmonary vascular resistance. It's at the level of the obstruction that they have the problem. So to try to lower someone's pulmonary vascular resistance out here, when they have a big narrowing here, doesn't really make much of a difference. But we still do it, but it's really somewhat theoretical. What people think happens is that you get this, what they call hyperpnic response. Kids breathe fast and hard. So by giving them oxygen, you're trying to reverse that. You're trying to tell the brain things are okay. You don't have to breathe so fast and hard. So they seem to calm down a little bit. So it's not, oxygen is sort of lower on the list of recommended treatments. Increasing systemic vascular resistance, either mechanically or pharmacologically, are the best things we do. The other thing we do is sedate kids. So you give them morphine. That's a classic drug for that. And the third thing is there's often some component of RV outflow tract obstruction that is what we call dynamic. It's usually the hypertrophy of the ventricle that's underneath the valve. And that, when the patient gets, and that's the other thing I should have mentioned, very commonly, it's when patients get dehydrated. They get dehydrated and these thick ventricles, they're squeezing like this, start to squeeze and totally collapse and have no output to the lungs. So you don't want to let a kid get dehydrated. So again, getting out of that warm bath, being a little dehydrated because they haven't eaten in a little while, and being vasodilated is like the worst combination possible. So it often happens in the morning when they haven't fed all night, mom stuck them in a bath, and next thing you know, they've had a TET spell. So giving them volume helps. And then the other thing that we do is we often will use, like this kid has, is anybody taking care of that kid here?
She's over there, so.
So that kid's on Esmolol. What's Esmolol doing? What is Esmolol? Yeah, it's a short-acting beta blocker. And what a beta blocker is doing is relaxing the hypertrophy muscle that is collapsing in the outflow tract. So it's getting the heart to relax. The other thing it's doing also is slowing the heart rate. So by slowing the heart rate, most of our filling during diastole occurs when it's slower heart rates. So you have more time, you relax the heart, you have more time to fill before you empty. So you slow down the heart rate to 100, 120, and that's probably the biggest effect of the beta blockers. But they've talked about it, just like with oxygen, as inhibiting that hypertrophic dynamic obstruction that's there in addition to the valvar obstruction or subvalvar obstruction. So those are the therapies we use for TET spell. Often TET spells are a murmur of the way in which patients are diagnosed. Some will be noted to be blue by somebody. But oftentimes it won't be diagnosed till later on in life. So, getting back to the original question, so we understand the anatomy and a bit about the physiology of tetralogy of Fallot. So why would you repair somebody early on versus repair them at a later age?
You would have to have some,
What's it?
how hypertrophic they're.
Yeah, any worse, especially for left ventricle.
So that's a great point, and actually one of the more modern, and we think real understandings of advantages of repairing patients early with tetralogy of Fallot is because the later they get, and you'll see some of these kids, we sometimes get these kids from foreign countries where they've never been diagnosed until late, or someone said they're not an operative candidate. So we get these 8, 9, 10-year-olds who get a TET repair. They can be sick as a dog because their heart has been so hypertrophied for so long, the right side of the heart working so hard against this obstruction, that the muscle itself doesn't just relax when you relieve the obstruction. It's still thick and non-compliant. So they have a very stiff ventricle that doesn't fill well, and you've just operated on it by putting a transannulator patch or a RV to PA conduit, so you've cut on that right ventricle. It takes some time for that heart to recover from that. And those kids can be very, very sick. And those are the ones we often leave, a PFO actually, because by shunting right to left at the atrial level, they can maintain filling of the left ventricle and cardiac output even if they're blue. But you don't want to, we think it is bad to try to operate, or more complicated to operate on these kids later in life than earlier in life in terms of the RVH. That's for sure true. But that's a relatively new understanding. What might be some other reasons why you'd operate on them earlier? And one of them you guys talked about is TET spells. TET spells is an indication for operation. Because your first TET spell might be your last TET spell. So once we think a kid has been spelling, we get a good history from the family, it sounds like that, we will operate on it. To avoid that rare instance, but not uncommon, where kids will drop dead. So TET spells is certainly something that buys you an operation. Potentially the weighing and balancing that significant right ventricular hypertrophy, another reason to do it earlier, although that wouldn't make a difference between a neonate and a 2-month-old, let's say. But what else? You mentioned it by accident. You said, pulmonary atresia. Pulmonary atresia means there is no pulmonary valve. There is no way for blood to get out to the lungs. They are ductal dependent. So if they have a ductus and they have no pulmonary valve, then you have to operate on them earlier. Otherwise, they can't leave the hospital or stay on prostaglandins, right? But there's another group that we deal with, the so-called tetralogy flow with pulmonary atresia and MAPCAs. And this is a version of tetralogy flow as well. It's one of the most complicated types of heart disease that we deal with. These are patients who typically don't have a ductus, they don't have a pulmonary valve, and their blood supply all comes from aortopulmonary collaterals. So big vessels that come off the aorta and go supply the lungs. And they may have native pulmonary arteries, but they're not really necessarily connected into the circuit. And those can be very complex kids, and depending upon their specific anatomy, they might need a neonatal operation as well. Some of them may get perfectly good flow through those collaterals and not need a neonatal operation. Sometimes to leave them alone might be the best thing you can do for them. So typically pulmonary atresia, typically kids who are spelling, but if we don't have those or someone who has such severe RV outflow tract obstruction but does have a native pulmonary valve, but they're so blue that we can't send them home. So that'd be the kid, who has SATs in the 50s or 60s. You can't necessarily, they're virtually pulmonary atresia. They're just going to be too blue. So we have to find some way to restore blood flow to their lungs. So those are the sort of typical indications. Other than that, you'd rather repair a kid at about 4 to 6 months electively. Let them get home, let them grow a little bit, and as long as they're not spelling, that's the time when we would typically repair it. We're not seeing a whole lot of those anymore because we just get the worst patients. I mean, we just get kids who have the most severe forms of these heart disease because tetralogy flow is something that's fairly repairable in a lot of congenital heart centers across the country. It doesn't necessarily take your guys' expertise to manage those patients. It's just like you don't see a ton of VSDs either. You see an occasional one and they're here for a cup of coffee and they're gone, So this falls into that category. It's one of the first forms of heart disease that was actually described and repaired over the history of congenital heart disease. But it's a very complex form of heart disease depending upon the severity of it, and there's a wide spectrum. The other thing you hear about is something called double outlet right ventricle with pulmonary stenosis, which is falling into the category of tetralogy flow. It has the same exact type of physiology. Those kids can spell. And the real difference is an anatomic one, and it's really subtle, and it's not that important from your guys' perspective. If somebody has double outlet right ventricle, that means they have a VSD, and it means they have pulmonary stenosis. Well, it doesn't mean if they have pulmonary stenosis, it means they have tetralogy like double outlet right ventricle. So those kids will get a lot of the same types of treatments as a tetralogy flow would. Let's see, what else? What questions do you guys have? So one of the things that we're considering now, so this patient that we have today was coming here, had multiple extracardiac congenital anomalies. May have a chromosomal abnormality for all we know. And was coming here for a G-tube, actually, with the idea that this kid would just be an elective repair 4 to 6 months, like many TETs. And by the way, these kids can sit down and hold it because we're not planning to do operations on them. So if they're not too blue, they can stay down there and treat whatever their newborn problems are. So this kid was sent from Lansing for that purpose and then got here and started spelling like crazy. Again, my guess is you take a baby and either stick him in a warmer and he vasodilates, or get him out in the cold and he vasoconstricts, and then you bring him inside and he vasodilates. I mean, there's some change in resistances acutely that triggered, or dehydration, that triggered something in this child to spell. And then we were doing knee to chest, we were giving morphine, we gave oxygen, we gave phenylephrine, the kid was still spelling. So this is like intractable seizures, you gotta do something. So he got intubated, he got paralyzed, he got morphine, he got put on a phenylephrine drip, got a little bit better, was SAT sort of in the 50s, got blood, which was important too. A lot of these kids, when they get anemic, will get worse. So we did all these things sort of simultaneously, and eventually the spell kind of resolved. The other part of that is this kid's been very hypoxemic for a period of time. You have to worry about what effect that has on their brain and other organs. So that's sort of what they've been trying to sort out. And now, because we have another option for these patients, which is, well, what is the surgical, sort of, what's your understanding of the surgical repair of tetralogy of Fallot? What do you do? I mean, fundamentally, you try to fix the problems that you described, right? So what do you do?
Close the VSD, usually with transannular patch, so your aorta's.
So you close the VSD, so there's no more shunting, right? But you can't do that if you're going to leave your right ventricle with no way of getting blood out of it. So if there's severe stenosis, you have to address that.
Right.
And what you do for it depends upon where that stenosis is predominantly located. If it is that anterior infundibular septum, like I said, the surgeons will cut that out. They'll get it out of the way. Part of the problem is, though, that because that's the mechanism for the stenosis, everything that's beyond that, the main pulmonary artery, the pulmonary valve, the subpulmonary area, maybe even the main pulmonary artery above the valve, the supravalvular area, may all be small because they haven't seen a lot of flow. So if they're below certain sort of anatomic criteria that we can assess by echo, then the surgeons may have to do more than just cut out that infundibulum. They may actually have to patch across the pulmonary valve. So it's like a tube, it's too small, you cut across it, you open it up, and you build a new roof. That's called transannular patch. When they do that, they, by necessity, create pulmonary insufficiency. There's no valve there anymore, but blood can get out. So if they don't have to touch the valve, they won't. But many times they have to cut across the valve, and maybe even sometimes onto the main pulmonary artery, just to get it large enough to allow blood to get out.
Is that something they find out when they go in? Or
It's something that we can tell them about ahead of time by echo. So the valve annulus, you know, a normal valve annulus, it depends upon the size of the kid, but it might be sort of in the order of, 8 millimeters, 9 millimeters, something like that. These kids can have, 2, 3 millimeter pulmonary valve annulus. And we've learned by experience that if it's below a certain cutoff, based upon the size of the kid, you have to cut across that pulmonary valve annulus. You can't leave it. It'll be too obstructed. And because, again, you close the VSD, there's no way for the blood to go anywhere. So that would be a real problem if you didn't relieve the obstruction. So they relieve the obstructions of the RV outflow tract, they close the VSD, and then usually there's also an ASD, which they may or may not close, depending upon oftentimes how old the kid is and how thick and muscular that RV is. The thicker, the more muscle, leave the ASD open, because for intensivists like myself, that's a godsend. Because every single time that blood wants to get out the pulmonary valve and the ventricle can't fill because it's too stiff and the right ventricular end diastolic pressure is really high, there's only one place for that blood to go, which is across that ASD to the left side. So the kid's really desaturated, but they're in great shape in terms of cardiac output. So that's pretty much what they do. Now, a couple of post-operative things to remember is tetralogy of Fallot is the #1 lesion that we see jet in. So TET and TET type kids, jet is something that's very common. We think of it more in single ventricles because we see so many, but it's far and away most common with tetralogy of Fallot insurgents. The other thing is, again, you have to maintain good filling of this ventricle, specifically the right ventricle, because it has been thick and non-compliant. It is not the pulmonary vasculature. It's as though the pulmonary vasculature has never relaxed since birth. You'd see the same thing in somebody who had idiopathic pulmonary hypertension, is that they have a resistance to blood flow out from the right ventricle that is fixed and is there since birth. The right ventricle never thins out like a normal right ventricle would. It's big, thick, and muscular like a left ventricle. So that's it. If you have an ASD, even if they're not shunting a ton right to left, what you're going to see is your right atrial or your CVPs are higher than your left atrial. And your left atrial pressure is reflecting not just the left atrium, it's reflecting your left ventricular end diastolic pressure. Because when the mitral valve's open, those two are equal. So there's very few lesions in which you'll see the right side is higher than the left. Because in normal, in all of us, the left side's higher than the right, which is why an ASD shunts left to right. So you should see CVP higher than left atrium. That's not surprising, and it's consistent with the type of physiology you're treating post-op. However, don't be fooled if they're both high. So if your CVP is 15 and your left atrial pressure is 15, this is a graduate level question. there's really two things that could be going on. What would you think those would be? So your blood pressure is marginal. You got low cardiac output syndrome. So you have blood pressures that are sinking, and you're calling the doctors. Your left atrial pressure is 15, I'll make it 18, and your CVP is also 18. So what's going on? Because I told you it should be higher than the left side, right?
So you have both high.
Both high.
Yeah.
Both high with low blood pressure.
Yeah, like back up.
So their SVR is way up.
No?
No.
Your SVR would be more about your systolic. Your SVR is really what during systole, what your ventricle is seeing. This could be true in anybody, but I think it's more common that we see this with tetralogy of Fallot patients, partly because it's not always as easily recognized. So one is cardiac tamponade. So cardiac tamponade is when your left and right atrial pressures are equal, they're both high, and low cardiac output. So you have to presume tamponade until proven otherwise. The other thing that does that is a large residual VSD. Because if you remember anything from this talk, it's my wife. It was my wife, actually. If you remember anything from the talk, when you have a pressure overloaded ventricle and you leave it acutely with a volume overload, it will not do well. If you take a volume overloaded ventricle and you pressure overload it acutely, it will not do well. So when you leave a large VSD, and you may not have even seen it because there may be more than one VSD, or the patch may be dehisce. If you leave a large left to right shunt and you've relieved the RV outflow tract obstruction, this is now a volume overloaded left ventricle and right ventricle that was formerly pressure overloaded. And they will be very sick with that. You know, a VSD, a large left to right shunt, is a volume overload on the left side of the heart. So that's why your left atrial pressure will be high. If you ever see anybody with a large VSD, their left ventricular end diastolic pressure is high, their left atrial pressure is high, their left atrium and left ventricle are dilated, and this will be the same thing, but it'll be done acutely in a patient that formerly had just seen a pressure overload. So those are the two things you ought to think about. If you have a high left atrial pressure that's unexpected in the tetralogy of Fallot post-op, it should be tamponade or residual VSD, both of which will make the kid really sick in the face of low blood pressure. So just something to watch out for. This is the kind of thing where you guys can be so valuable to us because we try to notice these things, but these trends will start happening. And you see it as trends. We see it as one snapshot in time.
So if it's the VSD, the treatment is to go back and fix
Go
the
back
VSD.
to the operating room and close the hole. Yep. There's not much we can do medically. So, but that's just a sort of a pearl of ICU medicine, which is, again, pressure overloaded ventricles, they're acutely volume overloaded, do poorly. So if you leave someone with wide open mitral regurgitation, and before they had a coarc, they're going to do terribly. Because mitral regurgitation is a volume overload on the left side of the heart, and a coarc is a pressure overload. So you fix the coarc, leave them with MR, they're going to be sick. So there's lots of combinations you can imagine where that could possibly happen. If if you had a patient who had mitral regurgitation and suddenly, they developed some sort of outflow tract obstruction, they'll be very sick because your heart's adjusted to a volume overload, and then you acutely give them a pressure overload, they're not going to tolerate it. So that's just a good sort of general rule, but it plays a role in this lesion as well. Questions?
Yep. So, sorry I'm behind you.
That's all right.
There was a chair there. So, what is, I got the symptoms, you're looking for symptoms, we don't treat people with surgery until you see significant. What is the ideal age then for a TET?
So
Would it be
typically,
like under 2 years old? Or?
no, we usually do them earlier than that, again, because we don't want to leave that ventricle under pressure overload too long.
But they've seen it at different ages.
Yeah. If it's elective, if the baby's born here, and we know about the baby, and there's no TET spells in the first months of life, which we will give the parents specific instructions of what to look for, we will electively repair them at about 4 to 6 months of age.
Okay.
So that's when you'd see a straightforward TET come in with no problems. If they have some of these other caveats, they may have to be operated on in the newborn period, but you'd like to wait. And the reason why you like to wait is partly because if you have, let's just say during the operation, I'll give you a good reason. one of the things we sometimes have to do is put in what's called an RV to PA conduit. And the reason why we put an RV to PA conduit is either you have pulmonary atresia, so there's no valve there to cut across, or you have some other anatomic problem that makes it such if you were to cut across the RV outflow tract, you could damage another structure. That other structure is typically a coronary artery. So a certain percentage of patients with tetralogy of Fallot have a coronary artery that goes right over the RV outflow tract. And if you cut across it, the kid's not going to do well. So they basically have to do it like a jump graft. They put a tube from the right ventricular infundibulum to the main pulmonary artery and bypass that area that they would have liked to have done a transcatheter patch on. And if you ever have to do anything like that, or if you try to cut across the valve and have a problem, then you want to do that at as old an age as possible, reasonably speaking, because your options become more available to you the older and the larger the child is. We don't really have any neonatal valves. So if you have to do something to put a valve in there in some kid who's a newborn, your choices are really limited. You use an aortic homograft, and an aorta from a child who died. You put it in the pulmonary position, and it'll fail within a matter of years, if not months. So we try to delay those things as much as possible if we have to do more extensive surgery. So that's one of the reasons why you like the kid to be older if you could. It also just makes the operation easier. Because remember, they're closing this VSD, typically they're doing it through the tricuspid valve. So they have this tiny little tricuspid valve, they're looking through there at a VSD that's up over here, trying to close it, and then they're trying to get to the RV outflow tract through that same tricuspid valve to open it up. And you know, it's not easy, it's very challenging. So, and these hearts are, you know, as you know, your heart's essentially the size of your fist no matter how old you are. So these babies have these tiny little hearts. It's pretty amazing what they're able to do in all the other lesions that we deal with. But this is one where you really want to get as good a repair as possible because it's possible you'll never have to do anything ever again. The long-term outcomes for tetralogy of Fallot repairs are excellent. We're finding more and more patients in their 30s and 40s that because they had a transannular patch and cut across their pulmonary valve, and they have no pulmonary valve, that they are now suffering from pulmonary insufficiency. So PR is something that over time will start to be a volume overload on the right side of your heart and cause your heart to dilate, dilate, and dilate. And at some point, that heart function will deteriorate, you'll have right heart failure. So this is where the Melody valve has come into play. Because the Melody valve, you've probably heard about, is a transcatheter valve that we can put into the pulmonary position. The number one indication is for repaired tetralogy of Fallot patients who've had a transannular patch. So you can put that into the pulmonary position, it functions as a pulmonary valve, it can stop the pulmonary regurgitation, allow that heart to shrink back down again. It's probably not going to be a permanent cure, but it might delay an operation 5, 10, 15 years. We don't know yet, because a lot of people are coming and having that done now, so there'll be a whole generation to find out. But it used to be, we always grew up that you were putting a lot of pulmonary valves into TETs at about 20, 30, 40 years old. Now they're mostly getting the Melody valve, and you're not going to see them until hopefully they're 50 or 60, if at all. So
That's wonderful.
that's one of the ways in which medicine has evolved, with new innovations. All right, any other questions? Does it all make sense?
We'll have to watch the video a few times, but it made a lot of sense.
I will do that.
Thank you very much.
You're welcome.